Hey, welcome everyone to today's webinar. We are going to be talking about implementation science today. What is it and how can health departments use its methods to end the HIV epidemic? We are recording the presentation part of today's webinar, but we will stop recording during the Q&A. And the recording and slides will be made available through the RAISE website as well as NASTAD's website. Please feel free to use the chat or the Q&A function to ask questions at any time. We will get to Q&A after the presentation. So today's webinar is a collaboration between RAISE and NASTAD. RAISE is the NIH-funded Research Alliance in Implementation Science to End HIV hub. This is a part of the University of Washington's Fred Hutch Center for AIDS Research. And NASTAD is the National Association of State and Territorial AIDS Directors. And together, our aim is to strengthen implementation science through public health by working with state and local EHE health departments. Our collaboration focuses on a few different activities, including today's webinar. So we do webinars monthly or bi-monthly on relevant topics. We also provide tailored health department consultations that are for EHE jurisdictions, as well as doing site visits or reverse site visits where the RAISE team will visit your jurisdiction or your jurisdiction can visit the RAISE team in Seattle to talk about how implementation science can support your work. And then we also host the Evaluating EHE Implementation Workshop. We've done 2 cohorts of this workshop for epidemiologists and others evaluating programs in health departments. So stay tuned for more information on the next round, which will be in 2026. So a little bit about NASTAD. NASTAD is a nonprofit association of public health officials who work in HIV and hepatitis programs around the country, including the 50 states, as well as the District of Columbia, Puerto Rico, the Virgin Islands, and the 7 jurisdictions that receive direct CDC funding, as well as the US Pacific Island jurisdictions. And how we do this is through the interpretation and influence of policies, conducting trainings and workshops, offering technical assistance, and providing advocacy mobilization for health departments and ministries of health. Here's our mission and vision statement. Our focus is on HIV, hepatitis, and the intersecting epidemics. At NASTAD, we have 7 unique teams, and each team is able to support and provide technical assistance to local and state health departments. Some of the ways in which we provide technical assistance, we do direct tailored technical assistance. This can be virtual or in person. We also do a lot of peer-to-peer learning through learning collaboratives, office hours, mentorship programs, and work groups. And then we also have leadership and mentorship programs for health department and CBO staff. We host a national technical assistance meeting for HIV and hepatitis programs, health department programs. We also do webinars and workshops, and then we have various resources and tools, all of which you can find on our website. So just some things that are coming up. RAISE and NASTAD are hosting a fall webinar series focused on prioritization of HIV research and public health HIV programming. We are in an ever-changing environment, and so it is imperative that we all focus on working with what little we have in a complex environment. So those webinars will be on October 15th, November 19th, and December 17th. We will be sharing information about those webinars through the RAISE newsletter, as well as the NASTAD EHE newsletter. And I'll be putting in some links in the chat later on where you can find information on how to join those. All right, so we're going to get to the main portion of our webinar today, which is providing an overview of implementation science and how it can be used to support your programs. So our presenter today is Dr. Kenneth Sherr. He is the director of RAISE, as well as a professor in the Department of Global Health at the University of Washington. So I will now pass it off to Ken.
Great. Well, it's a pleasure to be with you all today. And Krupa, thanks for the lovely introduction and also for the continued collaboration with NASTAD. And what I'd like to do is start with an overview a bit more on RAISE, the implementation science hub that Krupa introduced, one of our elements to you all, and just let you know about some of the other work that we're doing. And then give a brief introduction to what is implementation science, what's the motivation for implementation science, what's its definition, what are some of its I would say, defining tools for the field, and then some reflections on priorities for implementation science in the context of the Ending the HIV Epidemic initiative. So, as Krupa mentioned, RAISE is a regional implementation science hub. It's one of 9 regional implementation science hub funded through the NIH, and an additional 1 coordinating center out of Northwestern ISKI, which are funded to support and enhance implementation research as part of the EHE initiative. And all the hubs are similar in that they provide a mix of tailored consultation, some elements around capacity development. They're supporting multi-site research, and also supporting development of methods and tools and understanding how to deploy implementation science methods and tools in the context of HIV-related research domestically, and have some element of peer-to-peer learning, though each of the hubs have a bit of a different focus. And one of the big changes that we're really excited about is that all the hubs and ISKI, the coordinating center, received 5 years of funding in this year. Actually, beginning in 2025. Sorry, it's a typo there, and we'll be going for the next 5 years. So we built our hub around 3 aims. The first aim is to provide consultation services to NIH-supported Ending the HIV Epidemic research projects, and support these projects to meet reporting requirements and to upregulate or integrate novel implementation science methods into their work, and support them as they're linking with implementing agencies, and as hopefully scaling up their work into when the NIH funding ends into new projects. So we do this through consultations with NIH-funded EHE research projects, as well as development of resources focusing on building implementation science capacity amongst HIV researchers. Now, the second, which Krupa mentioned, is focuses on developing an implementation science health department learning platform. And this is focused on really how health departments can integrate implementation science into their work. And there's a series of activities we're carrying out. Krupa mentioned the webinar series, which this is a part of, and some exciting upcoming talks in 2025. We have recorded talks from previous years, and those that we're holding will be recorded and put onto a RAISE YouTube channel. As Krupa mentioned, we have health department consultations and site visits. And if you all are interested in accessing those, please fill out a request form and let us know, and we can get you on the schedule. And then Krupa mentioned the Evaluating EHE Implementation Workshop, which next will be in 2026. We've held 2 workshops to date. And we're developing a new workshop to be a second of the series of 2 for those who have participated in the initial workshop, which will go into more advanced topics of implementation science. So the intent of these workshops are to support EHE evaluators at local and state health departments, to incorporate implementation science methods into their program evaluations, to facilitate peer-to-peer learning across health departments, and to provide time for participants to develop a mixed methods evaluation plan. And then the advanced series will delve deeper into IS methods with select group of graduates to develop implementation science champions within health departments at the local and state levels. And then the third aim is to foster improved implementation of EHE activities focusing on HIV treatment through the establishment of health department learning collaboratives. And so we'll have two sequential 18-month learning collaboratives focusing on designing, implementing, and evaluating low barrier care and data to care strategies within HIV care systems. We'll be launching this in January of 2026 with an in-person kickoff meeting, and then we'll have monthly virtual group meetings and one-on-one technical support for teams, as well as drop-in office hours. And we're really envisioning this as a team-based approach where health department, HIV program staff, epidemiologists, HIV clinic, medical and administrative leadership, and additional partners form teams focusing on how to initiate, evaluate, and improve low barrier care and data to care strategies within their clinic systems. And if you or any of your partners are interested in participating in these learning collaboratives, please fill out an application. The applications are open and due on September 26th of this month. So we're really excited about what RAISE is going to be able to do over the next 5 years. I think it's really important, this initiative, to bring implementation science into the EHE initiative. Now I want to shift gears a bit and go into what is implementation science? What's its motivation? What's its definition? And what are some of the primary tools used in the field? So you may have seen something similar to this. This is the publication cascade. It describes the process through which original research gets into implementation and especially scaled implementation. And research is a risky endeavor. Oftentimes, original research is going to hit negative results. Maybe about 20% of our research just doesn't work. That's okay. But then when original research does show that there's promise, that there's a positive finding, well, we go into journal submission. Takes about half a year to get accepted. Takes another half a year sometimes for it to get into publication. And then once we have all a series of publications in a similar area, we'll develop bibliographic databases, reviews, guidelines, and textbooks, and then hopefully implementation and into scaled implementation. And it's estimated that it takes 17 years to turn just a fraction of original research to the benefit of patient care. So one of the primary motivations of implementation science is to expedite the process of original research getting into practice and to really squish these 17 years down to something which allows us to take advantage of the results from original research and to implement and scale in such a way so that we're able to leverage those evidence-based interventions to benefit patients and ultimately population health. And this has been known as the no-do gap. It's the gap between what we know works, largely from efficacy trials, phase 3 randomized trials, and then getting them into the do, getting them into practice so that we can lead to improvements in patient and population health. And these advancements in medical science continue to outpace application with real-world consequences. So it's estimated that there's over 10 million annual deaths from diseases with proven low-cost prevention or treatment strategies. And this includes 650,000 annual estimated HIV-related deaths on a global scale, 1.7 million TB-related deaths, over 6.5 million preventable child deaths, and 300,000 maternal deaths. And I always like to show this little pie chart from Tanzania. It's from a health demographic and surveillance system in a district called Rufiji in Tanzania, where they do a quarterly or 3 times a year a census of everyone in the population to look at migration patterns and morbidity and mortality patterns. And they estimate that over 85% of the disease burden could be addressed by available cost-effective interventions that are just not getting to the population. So implementation science doesn't just try and improve or expedite the translation of results into implementation, but really to increase or enhance the scale of implementation so that we can address this disease burden for which we have technologies just not in place or not delivered with sufficient quality to lead to improvements at a population health level. And in the HIV space, we see a similar no-do gap within the US. So We estimate that only about 25% of those who could benefit from PrEP are prescribed PrEP, and more than 1.2 million people could benefit from PrEP. So it's a large no-do gap in the PrEP space and in the HIV testing space, where less than 40% of people in the United States have ever been tested for HIV, and about 80% of annual HIV infections are transmitted by people who don't know they have HIV or who are not in HIV care. And looking at the HIV care continuum, we've made striking improvements in terms of diagnosis and enrollment in care, retention in care, and viral suppression, but we're falling far short of the 95, 95, 95 targets. And I would argue that we have all the tools, the evidence-based interventions available right now to achieve these targets. And it's a question of deployment, of quality of delivery, and of ensuring that these tools are getting to the populations that need them. Now, I want to I work in global health. I'm a professor in the Department of Global Health, so a lot of my examples come from low and middle income country settings, particularly in Mozambique. And I always like to put up this slide, which is where they carried out a survey of 32 health facilities with comprehensive HIV care. This was before the test and treat era. And they pulled patient charts on about half of patients who were on antiretroviral therapy and half who were pre-ART initiation, and just looked at if guidelines, the Mozambican guidelines, were implemented as aspired to. And as you can see, that there's a gap between aspiration and action. And this can be seen in terms of CD4 testing being carried out in the last 6 months, patients who are eligible initiating ART, cotrimoxazole prophylaxis, or whether patients who were HIV infected in the HIV care system had evidence of being screened for tuberculosis, which only 18% of patients had evidence of being screened for tuberculosis. And I like to put this up because of the next slide will demonstrate when you disaggregate the data, and this is what I tend to see across really any care system, is that there's a tremendous heterogeneity in terms of performance or implementation of guidelines across geographic space, across health facilities. And these are the 32 health facilities that were included in this survey, looking at the proportion of patients who had evidence of TB screening in their charts. In blue or purple are patients who are not yet on antiretroviral therapy. On dark red, purple, magenta are those patients who are on antiretroviral therapy. And you can see that health facilities varied tremendously in terms of performing TB screening for patients who are living with HIV in their care system. So you can look at this in the center, one high-performing provincial hospital called Shai, where almost 90% of patients who were in the care system who had initiated antiretroviral therapy had evidence of tuberculosis screening, while in Chimoio Provincial Hospital, a very similar hospital in terms of its size, its staffing patterns, less than 20% of patients had evidence of tuberculosis screening. And this brings up really the importance of context and disaggregating data to understand why is it working so well in some places and not well in other places. And in the field of implementation science, we say often context is king. It's really such an important determining factor for performance in delivering evidence-based interventions. And it shows that every process is perfectly designed to give you exactly the outcome that you get. So what can we learn from Shai Provincial Hospital to try and lift all the boats in terms of performance in implementing guidelines? So implementation science really tries to delve into context, how and why things work differently in different contexts, and then how can we oftentimes not just adapt to context, but maybe even change context so that we can improve delivery of our evidence-based interventions. So I'd like to make a distinction between implementation practice and implementation science. I think a lot of us are working in clinical settings or in health department settings where we're really supporting implementation practice, where we're using purposeful actions to put an evidence-based intervention into practice. So this could be through the EHE planning process, through funding allocation, through supporting the capacity to implement or put into practice those evidence-based interventions. And what distinguishes implementation science is really its focus on generalizable learning. So it's a multidisciplinary field designed to generate evidence to explain and predict translation of research results and evidence-based interventions into practice to improve public health and to yield effective methods uncovered through this process. So what we're trying to do in the field of implementation science is not just improve practice, but to learn about why is it that implementation is suboptimal in some places and better in other places? How can we take those learnings and generalize it and disseminate to support or improve implementation across contexts? And then what can we learn about from a more methodologic standpoint about the tools that we use to deploy these tools routinely in order to understand determinants for implementation and address those determinants to ultimately improve the implementation of evidence-based interventions. And you may have seen something like this, the translational highway for for different domains and types of research, where we're asking and answering questions that are really different as we go from discovery to improving health outcomes, ultimately at a population level. In the area of discovery, and a lot of this is in, science in the laboratory, where we're working to define mechanisms and targets, identify new diagnoses and treatments and prevention methods. And ultimately, this leads into the development of interventions that we're testing in highly controlled conditions. This is the development stage. You may have heard of it referred to as bench to bedside. So we're going from the laboratory bench into the clinical setting to demonstrate that the new intervention has the potential to lead to improved understanding of disease and lead to improved diagnosis and control of disease. At the far end of the spectrum, we've got T4, which is where we're looking to improve population level health outcomes. This is really studying what influences the health of population. So under this, a lot of this is large scale health services research or evaluations. But the bridge between the development of an evidence-based intervention and leading to improved health outcomes is this black box of delivery. And delivery systems are really I would say the primordial link for taking advantage of those evidence-based interventions for improving the health of populations. And here we're exploring how to deliver evidence-based interventions in real-world pragmatic settings. And I put it up here as a black box because delivery systems are complex. They need multidisciplinary methods to understand what are the drivers for delivery systems working as they do and how to improve those delivery systems. But I've also heard delivery systems referred to as a black hole because they cost a lot of resources and it's not exactly clear which levers are going to be pulled by putting resources into the system to lead to improved health outcomes. But implementation science, from my perspective, really focuses on these delivery systems or health systems, because if we're able to explore how to deliver evidence-based interventions in real-world settings and improve the delivery of those interventions, then our targeted improved health outcomes can be attained. So there's a number of definitions out there on implementation science. The field really only started materializing about 20 years ago. That in 2006, the journal Implementation Science was launched, which I'll say was the beginning of the field when you have a journal. The NIH's definition really distinguishes dissemination research and implementation research. And I thought it'd be valuable to go quickly over how the NIH is viewing dissemination and implementation research. Dissemination research is the scientific study of the targeted distribution of information and intervention materials to a specific public health or clinical practice audience in order to understand how best to spread and sustain knowledge and the associated evidence-based interventions. So this is the opposite of diffusion, where you naturally say, well, publish a guideline or put out a new technology and see how it diffuses across a population. Dissemination research is actively trying to expedite, again, that distribution of information in intervention materials like guidelines or best practices to specific public health or clinical audiences. Implementation research, on the other hand, is a scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve patient outcomes and benefit population health. So here we're really testing strategies that improve the adoption, and integration of those evidence-based interventions into varied settings, looking at improvements in patient outcomes and a scaled enough version to ultimately lead to population health. At the core, implementation science is a multidisciplinary approach. And one of the things I love about implementation science is that it's trying to bring in the perspectives and the tools from multiple disciplines to understand and improve those delivery systems. I was trained as an epidemiologist and started and worked for many years in implementation, and then made the transition more to implementation science. When I saw that really that there was an opportunity for layering research on top of implementation to better delivery systems, and became, I'd say, part of this multidisciplinary perspective where if we really want to understand complex delivery systems, we're going to have to think about how do we leverage those methods and tools from multiple disciplines, including surveillance and data systems, impact evaluation, economic evaluations. How do we leverage the tools of the social sciences and qualitative and mixed methods research? How do we leverage tools from industry and industrial and systems engineering, looking at operations research in terms of large-scale mathematical models to guide decision-making, and bottom-up improvement strategies like continuous quality improvement or systems analysis and improvement? What can we leverage from organizational psychology to understand organizational level determinants for implementing change and address those determinants to improve organizational readiness? And as well as dissemination research, stakeholder and policy engagement, and social marketing as a tool of dissemination research. So at the end of the day, it's going to really be a multidisciplinary approach, a team-based approach that is going to help us to understand and improve how delivery systems operate. So when we think about studying implementation, Enola Proctor, who's really one of the leaders in the field of implementation science out of Washington University in St. Louis, came up with this conceptual model around how intervention strategies, or those evidence-based interventions, ultimately lead to client outcomes. And those intervention strategies will, and I would say the usual has been, oh, there it is. The usual has been, does that evidence-based intervention work? Does it lead to improved client outcomes in terms of satisfaction, in terms of function and symptomatology? Does it reduce disease burden or prevent disease or cure disease? While implementation science has largely focused on how do we develop strategies, which can be at the systems level, the organizational level, at a group level, it could include things like supervision, or it could be focusing on individual provider consumers, lead to improved implementation outcomes, lead to improved feasibility, fidelity, penetration, acceptability, sustainability, uptake, and costs related to the evidence-based intervention, which will then lead to improved service outcomes or more effective delivery systems, and then lead to those client outcomes. So implementation science has focused traditionally on studying this link between implementation strategies and implementation outcomes. But as the field has matured, I think it's become clear that really implementation research covers this entire spectrum, from developing implementation strategies developing evidence-based interventions, proving they work, to improving the deployment and understanding how to implement them to improved implementation outcomes. So at the heart of implementation science is a distinction between implementation strategies and evidence-based interventions. Those evidence-based interventions are the 7 Ps: the programs, practices, principles, procedures, products, pills, and policies that we know improve health behaviors, health outcomes, or health-related environments. This is the what we are trying to implement. While implementation strategies are actions to enhance the adoption, implementability, and sustainability of evidence-based interventions. This is the how we are trying to improve implementation of the evidence-based interventions. So what I like about this definition of EBIs is we're not talking just about vaccines or pills. We're talking also around programs, practices, procedures, principles, and policies that are in place that we're trying to improve implementation of. So if we're thinking about from a health department perspective, the HIV program, whatever are in the guidelines for programs at a local or a regional or a national level can be seen as what we're trying to improve implementation of. And those implementation strategies that we're developing and testing and hopefully routinizing into practice are really focusing on how are we going to improve the implementation and the reach and the effectiveness of evidence-based interventions. So really, the core of implementation science is development of implementation strategies, and we'll come back to that. We talk about what implementation science means for ending the HIV epidemic in the U.S. And another core component for implementation science is the use of theories, models, and frameworks, and there are many of them. You all may have been exposed to the theories, models, and frameworks through some of the work that you or colleagues are doing and wondered, well, what are these frameworks? How can I get my head around the over 70 frameworks that have been described in the field of implementation science? And there's a couple of different ways that they're used. And I just want to briefly go through kind of one way to think about how to categorize implementation science theories, models, and frameworks, which can be a guide then for identifying what you would want to use or could deploy in your work. So the first set of or category of theories, models, and frameworks in the field are those that focus on describing or guiding the process of translating research into practice. So these are called process models, and they describe or guide the process of translating research into practice. And they're really action-oriented models to provide practical guidance in planning and executing implementation strategies to support implementation. So you may have heard of the PRISM model or the EPIS model or the dynamic sustainability framework. These are all examples of how you could use a theory model framework to guide steps to take evidence-based interventions and put them into practice in such a way that they'll be, for example, the EPIS model explored, they'll be deployed to penetrate within an organization, they'll be implemented and then hopefully sustained. And a second group of theories, models, frameworks are those that are designed to understand and or explain what influences implementation outcomes. An example here are determinant frameworks, where the goal of these frameworks are to understand or explain what influences implementation outcomes. So they specify the types of and the domains of determinants that are barriers or enablers or independent variables that influence implementation outcomes, those dependent variables. And some of the better known determinant frameworks include the Consolidated Framework for Implementation Research, the CFIR, which is one of the most commonly used frameworks in the field. The Theoretical Domains Framework, which also is very commonly used, or the Active Implementation Framework. And then finally, the third major category of implementation science frameworks are those evaluation frameworks, which are used to guide evaluations and to specify aspects of implementation that could be evaluated to determine implementation success. These are quite useful for standardizing how we report results from implementation research and what we're measuring in such a way not just to get at is something effective, but what are the different elements of effectiveness that we're interested in terms of deploying, implementing, and scaling up interventions. And a commonly used framework is the RE-AIM framework, which is Reach, Effectiveness, Adoption, Implementation, and Maintenance framework, which really focuses on those active ingredients for public health impact. Not just does something work, but is it reaching the population that we want it to? Has the intervention been adopted by organizations in the study setting? Was it implemented as intended? And is it maintained? Is it sustained, or are elements in place to sustain implementation of that evidence-based intervention? Another is the Enola Proctor Implementation Outcomes Framework that I introduced, or the Precede Proceed framework. All right, that was my lightning introduction to implementation science, kind of its motivation, its definition, and two of the core methods of the field, which are implementation science theories, models, and frameworks, as well as implementation strategies. Now, I want to give a couple of reflections of how implementation science could be prioritized within the context of ending the HIV epidemic. The first, I think we all know this, is that the ending the HIV epidemic has highly ambitious targets, and the national HIV/AIDS strategy has a goal of a tremendous reduction in HIV infections by 2030. And in order for us to kind of meet these ambitious goals, we're going to have to figure out, this is going on now, but continue to figure out how we can really bend the curve and expedite implementation of evidence-based interventions across the EHE pillars. So the first area of where implementation science can support EHE is around the development, testing, and scaling up those implementation strategies focused on the evidence-based interventions of EHE. So this includes what works in terms of implementation strategies, how do they work or not work, what are the determinants for implementation and the mechanisms for their effect, and under what conditions, across which context do they work, and why do they work in some contexts and not others. Learning about the contextual factors that influence implementation strategies will help as we translate them to other settings or take them to scale. And also, what do they cost? What is the benefit for the cost? So some examples of implementation strategies that could be tested are around PrEP navigation. Does PrEP navigation as an implementation strategy work? So what do you get? What do we mean by what do you get? Does it work similarly across contexts? And what does it cost? So really important information if we want to scale up PrEP navigation or spread it to other settings. And another is, how can behavioral economic strategies, incentives, enhance demand, and does it lead to improved program effectiveness? So a lot of the work that's going on in the context of EHE-supported implementation research is really focusing on developing, testing, spreading, and scaling these implementation strategies. And if you're interested in learning more about implementation strategies, there's a couple of useful articles and a lot of work going on to collate, not just do strategies, what are the strategies, but put together information about which strategies work and where. There's a paper by Waltz and others who took the over 70 strategies that have been identified through what was called the ERIC, or Expert Recommendations for Implementing Change, which are where they went through and identified implementation strategies domestically here within the US. Is that there's different categories of strategies. You can have strategies that are focusing on local evaluation and iteration. Others that focus on adaptation and tailoring to context. Others that focus on training and educating stakeholders. Others on engaging consumers, changing infrastructure, providing interactive assistance or facilitation, developing stakeholder relationships, supporting clinicians, and utilizing financial strategies. So if you're in your work and you want to go further in understanding what's out there in terms of implementation strategies, this is a great place to start. There are many of them, and a lot of work that ISKI is doing, as well as the regional consultative hubs, is trying to understand in the context of EHE which implementation strategies work and how do they work, and to disseminate that evidence in such a way so that it can support health departments and other partners to adopt, adapt, and implement implementation strategies in their setting. Now, another area where implementation science can have a role in EHE is supporting the scale-up process to maximize impact. So EHE is all about scale within the priority jurisdictions. And there's a distinction between spread and scale up. So spread is adopting and replicating without much modification of an intervention in a health system. But scale up is something different. It's addressing the systems and infrastructural issues that arise during full scale implementation. So as we're looking to take not just the evidence-based interventions to scale, but also implementation strategies to scale, we have to be thinking about how we address those systems level determinants so that we can maximize the potential of those EBIs and the implementation strategies as we reach broader geographic and population coverage. So some examples of the types of questions that could be asked here could include what works to scale up effective implementation strategies while retaining effectiveness when expanding to new populations, when we're implementing through new delivery systems, and what happens when you have attenuated oversight when you go to scale, given that largely the pilot into initial effectiveness trials tend to be highly controlled. And when you go to scale, you're working through delivery systems where there tends to be less focus and oversight in terms of implementation of those evidence-based interventions and strategies. Another is how can scale-up planning be routinized in EHE planning and support? There's EHE planning has a formal system, and can we put into that planning approach thinking about scale from the beginning and addressing those, trying to predict and address those systems level and infrastructural issues that are going to be essential for achieving scaled implementation. Now, as Krupa mentioned, we are in interesting times in terms of funding for health globally and domestically. I don't have information available now in terms of what's happening to our budget for the HIV response domestically for the next fiscal year, but in the global setting, we are seeing a tremendous reduction in funding. So these are trends in development assistance for health from 1990 to 25, inflation adjusted. And you can see there was a large ramp up of funding associated with the HIV response. Largely, this was PEPFAR and Global Fund funding, and then a big peak with COVID-related support. But we're looking at funds, a market reduction in funds for the next fiscal year, taking us back to where we were around 2008. So this is going to raise some really important questions for sustainment of activities. And so in the context of sustained implementation, the implementation science could be used to help prioritize existing resources amid oscillations in funding inputs. So where do we want to put our resources? What's going to give us the biggest bang for our bucks? And how can we most effectively use those resources that we have available? And as inputs change, revisiting those questions. And then a really important question, given potential changes in federal assistance, is will states have the funds to absorb activities? And amongst those activities, which activities should be sustained and in what form? Really predicting that we're going to have some changes in how we implement and what we're implementing to conform with budgets if we're going to more state and local financing for the HIV response. So examples of questions include, what's the cost per case of HIV detected? And how can EHE jurisdictions prioritize efforts to navigate the changing political and economic landscapes? We're going to have to be very nimble as the funding landscape and the political landscape changes, and how can this be done? How have successful jurisdictions done this, and what are the learnings from that process that can support other EHE jurisdictions as they navigate potential changes at their local, state, and at the federal level? And another big question is how can we address inequities in the HIV response? We know that the number of new HIV infections is not homogeneous. It's not the same across geographic areas. That's why EHE was initiated, to focus on high need jurisdictions, nor across particular populations. So if you look at number of new HIV infections by subgroups, we have a continued disproportionate number of new infections in some populations over others. So how the questions for implementation science is how can we better address these inequities? So first is describing what are the prevalent inequities and are they routinely measured? So if they're routinely measured, we can better describe and monitor those inequities and ultimately evaluate whether our strategies are addressing inequities, which is going to be essential for achieving our overall goal in reduction of new cases of HIV. And then part of this is what are the modifiable determinants of these inequities? Why do we see these inequities in specific populations? And amongst those determinants, which can we actually address? Which are modifiable, and so that we can start addressing those determinants of inequities and hopefully ameliorating the inequities across populations. And then what are effective scalable strategies to address inequities across the EHE pillars? We really have to be thinking about, especially given the current financing or financial input oscillations, which are not just what works, but what is going to be scalable and that will be not cost prohibitive to address these inequities across the EHE pillars. So some examples of questions that we can be looking into: do cash transfers improve the effectiveness of HIV prevention and control outcomes amongst the most marginalized populations? And what unintended benefits are observed? Does it spill over to other populations? And can directed clinical services improve engagement in the HIV care continuum? Low barrier care and data to care services. I mean, can these lead to improved engagement in HIV care and ultimately to improvements in viral suppression? All right, final slide on what implementation science can mean for any of the HIV epidemic. And I think just ultimately for the investments in implementation research to lead to improvements in EHE planning and execution, it's going to require a really tight and integration between the research enterprise and the implementation, EHE implementation enterprise. So for this to work, research is going to have to be relevant. It really needs to be positioned to answer the priority questions among EHE jurisdictions. It's got to be fast. The results are going to need to be are going to need to come out quickly and be provided to the implementers in a way which is useful for them. And it's going to require engagement. So EHE jurisdiction personnel are going to have to be engaged throughout the entire process in order for the results to be relevant and to expedite the translation of results into changed practice. So this is easier said than done. The research enterprise is in some ways calcified in terms of how long it takes and how projects are designed and research projects are designed and carried out. So it's going to require really a reframing of the research enterprise in order to integrate with health departments. And so how can this be done? What are some of the lessons learned to develop a fruitful platform for health department and research institution collaboration? Well, the first is shared funding. And shared funding with limited indirects, meaning that it does not reduce the health department funding. Some of the work that is being supported or much of the work being supported for implementation research in the context of EHE is going to require supporting organizations, including health departments, to implement implementation strategies. And so that is going to require that shared funding. So it's not going just through the research institutions, but it's getting into implementing agencies. Another way to build a fruitful platform is to think about shared positions. So is there a way to have academic people who are based out of academic institutions have a role in terms of medical leadership, have a role in data analysis as a PhD trained level epi at a health department, et cetera? There are some good models for this here in Public Health Seattle King County. Matt Golden, who's a professor of medicine, he directs our HIV, STI, and Hep C control efforts. We have a number of epidemiologists who are based at the University of Washington who fulfill a role or work out of the health department. So this can help to, by sharing positions and sharing funding, it can help to create a long-term collaboration and really change how health departments are able to not just tap into technical resources, but to bring novel ways of thinking into their work. And then another is shared goals. So there really needs to be a relationship that's built that's based on trust, that's based on progress turns towards long-term goals. And and if coming in, I'm based at a research institution. I've worked a lot with ministries of health, but coming in with my research goals is going to do little to build trust. So really building that trust and understanding what are the positions of health departments and supporting them in their work through those long-term relationships is one way to build this platform. And then finally, sustained commitment towards partnership is important, and that's at both levels. That's at levels of health departments or implementing agencies and research institutions. So if there's a commitment to working together towards improving EHE activities, then that platform can bear fruit. All right. I want to thank you all for listening to me. We've got about 10 minutes for discussion. There's our Raise has a listserv with advertisements for some of our activities, so please join it if you haven't already. And I'm going to stop sharing here.